forgotten how it felt before the world fell at our feet. There's such a difference between us and a million miles. Hello from the other side. I must have called 1,000 times to tell you I'm sorry for everything that I've done. The way I call you never seem to be home. Hello from the outside. At least I can say that I'm trying to tell you I'm sorry for breaking your heart, but it don't matter. Clearly doesn't tear you apart anymore. Hello, it's me. I was wondering if after all these years you'd like to me to go over everything. They say the time's supposed to heal the earth, but I ain't done much bleeding. Hello, can you hear me? I'm in California dreaming about who we used to be when we were younger and free. I've forgotten how it felt before the world fell at our feet. There's such a difference between us and a million miles. Hello from the other side. I must have called 1,000 times to tell you I'm sorry for everything that I've done. The way I call you never seem to be home. Hello from the outside. At least I can say that I'm trying to tell you I'm sorry for breaking your heart, but it don't matter. Clearly doesn't tear you apart anymore. No, I I wanna run away.
Okay, good morning, everyone, and a warm welcome to all of you to this first-of-a-kind HPBridge session. We will start immediately. Just one piece of information. We will skip the announced break, the formal break at 9 o'clock, because it's so close to the end of the program, so we'll just run through easily. If you need to refill your coffee cups, just sneak over in the corner and refill them as silently as you can so we don't make a formal break, but go through, probably stop a bit ahead of time. Okay, so I am Kristoffer Lassen from Oslo in Norway, and my co-chair is Isak Galatisse from Ile-Ife in Nigeria. And it's a pleasure to introduce Brendan Visser from the United States, who will give you a brief background on this project.
Good morning. We're so pleased to see folks here early, because some of you were in the bar last night till late as well, I'm sure. So HPBridge is an exciting project that is a collaboration between outreach and education and training. The clever name, I need to give credit to a Dutch postdoc that the Dutch Pancreas group sent to us. And they have a specific talent in coming up with clever names, and so I have to give Hester full credit for the title, because HPBridge really, as a hepatopancreaticobiliary international bidirectional engagement and collaboration, that's really the whole kit and caboodle. So otherwise, actually, I can just get off the stage and move on, because that's describing the intent of the program. The idea here, of course, is really to facilitate collaborations among and between and among HPB units across the globe, and to share our knowledge. And this really grew out of a desire for ongoing direct interaction and professional relationships across individuals and units, beyond the intermittent opportunity to meet each other and share knowledge that we have at congresses like this, which are fantastic. But obviously limited in their scope. And it was inspired by some international collaborations that existed that had grown organically and were really, had developed some deep friendships, some terrific engagement that contributed to positive patient care and learning for those individuals. So this is sort of a set of principles that was guiding, that is guiding the HPBridge project, and will help it evolve, falling back on these principles. But it really boils down to two things, which is shared learning and connectedness. And fundamentally, that is what this organization is about. And so it's really falling back to those two very strong principles that are sort of foundational to it. So HPBridge, once we put out our sort of call for interested parties, there was a lot of folks who are clearly engaged in this kind of a project. So we had 90 applicants, and in this initial phase, 29 of those centers were grouped into 6 groups, 2 in Asia Pacific, 3 in Europe, and 1 in the Americas. And in the first round of MDTs, there were 280 participants, and that number keeps growing and will continue to grow as the number of MDTs for each of these groups grows. The MDT is the sort of foundation for these interactions. It's a starting point to be sharing knowledge and, honestly, for folks to get to know each other and then organically develop that connectedness that will allow additional collaborations in the future that we'll talk about a little bit. So this morning's agenda is here. So we're going to learn a little bit from some of the successful collaborations to sort of figure out how best to do this, what are the best practices of sorts, and what has been learned from collaborations that pre-existed and those that are continuing in the HPBridge format. And we're going to do a little bit of sort of HP bridging here, which is to talk about some cases, have some cases presented that will allow interaction. We also have worked with some individuals to really begin to dig into the need and do this in a way that is allows us to learn what is the need, what's the desire among all parties who are engaged, so that as we scale this and their sort of iterative changes, we really are reacting to the best way to move forward. And so we're going to have an opportunity to learn about that qualitative research this morning, and then Dr. Kingham will finish us off to talk about future directions. So we're very excited again that everybody's here this morning, and with that we'll start with Meehan.
Great. So the first speaker, as you heard, was Meehan Sirvardana from Brisbane, Australia.
Thanks, Christoph, and thanks, Brendan, as well. It's a real honour to be here, and I'd just like to say that this whole experience for me and I think for us as a group has been a tremendous privilege, and today I'm hopeful to give you a little bit of an idea how it all started and some of the collaborations that had been existing that perhaps motivated the process. And so just to give a little overview, I'll speak for a very short time about my background and maybe how that influenced a little bit how I was thinking when we got together to generate this process. An example of the collaboration that we've been talking about, some of the concepts that I think make great collaborations within the HPB world, and then how this ties into HPBridge. First of all, as Christoph said, I'm from Brisbane, Australia, and I was a child of Sri Lankan immigrants who migrated to the United Kingdom, and I think that link, I always had a strong passion to try and relink with, I guess, my parental roots, and that was perhaps the impetus for some of the things that have motivated me and have been a passion during my career as an HPB surgeon. I was very lucky to be involved in the Training and Education Committee for IHPBA for the last 7 years, and through that connection with Brendan and then Peter and then Christoph and Alejandro, the concept of HPBridge started to develop, and then through this process we've learnt a lot and we've developed something that I think is quite special. So the first interaction I actually had in Sri Lanka was when I was on holiday, and I happened to visit a hospital through a friend of mine that was doing some laparoscopic cholecystectomy on the day, and I was a fellow at the time, and I went to watch them perform it, and they're very skilled surgeons, but immediately I could see that there was a discrepancy between their practice and our practice, and it wasn't a lack of skill or even equipment. In fact, there was something fundamentally that was different, and through that interaction we came up with a process to develop workshops to just develop basic laparoscopy in Sri Lanka. And that was the lead point to then connect with other groups through the IHPBA to then create a more formal network to try and develop HPB surgery in Sri Lanka. And so this involved, I think, a threefold process where initially there was a really important step where we engaged with people. Then we used the MDT as the centerpiece of our interactions. And then finally, I think the evolution and the maturation of that process was to develop fellowships and training programs for people from Sri Lanka. This then evolved even further beyond Sri Lanka and even beyond Asia. And ultimately, as it stands now, in this current collaboration, we have 12 different sites in 5 different continents participating regularly in our MDTs. It is a challenge, and I think it takes a lot of effort to arrange and to maintain something like this because of, you know, the nature of time differences, the nature of people's commitments. But it's amazing how willing people are to engage when there's a connection and relationship. So why was the MDT the centerpiece of this process? And I think there's a number of different factors involved. I think the first thing is that you know, when you're separated by a large distance, having some way to interact regularly allows a relationship to evolve and continue. The other big thing I think is that MDT is a real cornerstone of practice now, particularly in high-income countries, but it's less utilised in low-income countries and even middle-income countries. And so it was an opportunity to infiltrate centres that were not using it as regularly. And then I think finally, as a specialty, hepatobiliary surgery has complex care, and this lends itself to this MDT model and interaction like this. So this is what a sort of typical meeting looked like, and I have to say I was very lucky to have some of the people involved very early on, particularly Ajit Siriwardena, Rahan Jayaraja, Mariano Jimenez, and I think them giving up their time at very awkward times of the day and their expertise was critical to the success of such a relationship. Another critical factor, I think, which is sometimes undervalued, is a local champion. So I think each centre that's involved in this process must have what we, I think, coin a local champion. What I mean by this is someone who understands their environment and understands the needs of the people in that environment, and have a quite singular determination to improve the healthcare in this area, not for personal gain or benefit, but just through that empathetic goal. I think they have to be open-minded and they have to be generous, and I think it's not easy always to find this combination in individuals, but when they're found, I think it's a very valuable resource for that particular unit. The person I showed in the previous slide was from Sri Lanka, Kuda Galkedia, who's a critical figure in developing our link and our collaboration. Pictured here is Professor Tintin Ma, who I put as an example of someone who's overcome a lot of barriers to develop HPB surgery in her country, despite significant political turmoil, even oppression of some of the surgeries they were performing. She continued to drive the cause for HPB surgery and also to continue to interact with us in our MDTs. Sometimes even they were not allowed to speak about certain topics because they knew they were being heard at the time of MDT. And so I think as this process matured, the relationship built over time. And I think this is critical. One of the interesting things I saw is people who interacted, who had no real connection with these countries, developed a meaningful relationship. Pictured down the bottom there is Nico Rourke, who's a big personality, but having been to Sri Lanka once to conduct a workshop, he developed a connection with them such that he's visiting again and performing another workshop later this year. Pictured above in the top picture is a fellow who spent a year with us in Brisbane. He was critical during the war period in Sri Lanka and trained in a hospital that dealt with a lot of the problems during the war. And so I think there's a real need to develop relationships beyond just virtual meetings, and in-person interaction I think is critical to that. One of the letters of HPBridge is the B, which is the bidirectional aspect, and I think this is also something that was a part of our collaborative. I think all groups within the collaborative have benefited in some way. There was a particular case that I benefited on of Haidata disease in a young woman from India who had migrated to Australia, and we often took more radical approaches to this, but on advice from some of the surgeons from Myanmar who deal with this very regularly, we took a less radical approach, which I think benefited the lady. We also have some plans in process to try and exchange junior doctors to try and enhance their experience, and this is a bi-directional process. And then finally, we've just started a project to try and reuse single-use equipment between Australia and Sri Lanka, where it's actually frequently done. And so how did this lead into HPBridge, and what can we learn from some of these collaboratives? And I think there's a few key qualities that I think many of you here who are now involved in HPBridge demonstrate, and these were some of the thoughts in our process when selecting the different groups. And generosity, I think, is the biggest factor. You have to give up time, you have to give up even money sometimes, and you have to give up your expertise. And having like-minded people who think like this, have this generous spirit, I think is critical to the success of a collaborative. Persistence is really important, and I think that goes with patience. Persistence to deal with ups and downs in this process. Sometimes the meetings don't happen, sometimes people don't turn up. But if we persist with it, it does tend to build a relationship that lasts. And ultimately, I think it's kind of like creating a family. I know that's a bit of a cliched term, but I think that's the best form of collaboration we know of as human beings, and I think ultimately that's what we're aiming for. The picture on the right is actually, I think, a poor collaboration. It's a family of impalas that I learnt that the male in the background basically doesn't eat or sleep. He just watches out for his harem of females. So then this led on to HPBridge, which I think Brendan has really summarised very, very nicely. But if I could just emphasise, the goal of this was to bring like-minded people together, build relationships, use the MDT as a starting point because we all are separated by distance. But really the personal interaction like we have here today, I think is critical to the success of this process. And I think ultimately one of our goals is to try and facilitate people visiting each other and understanding more about their environments. I'll leave you finally with a quote from Bill Gates, which I think we can go beyond. And he may be slightly out of context, but he said once that the point is not for the giver to have a good feeling, but the people we're trying to help to have a good feeling. And I think in this process, we are all givers and all receivers. Thank you.
Thank you, Mian. We'll have one more talk before we open for questions. So as another example of a collaboration that was ongoing before this bridge program started, we've invited Vuletav Chane from Addis Ababa in Ethiopia.
Good morning, everybody. Thank you for the opportunity to speak on this stage. So I will talk just on some of the success experiences that we do have in the collaborations. So I don't have much experience, but I will just focus on few of the
Green is onwards. Big green.
So collaboration, as it said before, is mandatory. So we might consider running alone will going to make us successful, but running alone will not going to make us successful. The best example is, if I'm not mistaken, the fastest man in the world is Usain Bolt. So as you know, he is the holder for the record in 100 meters short running, and his time is 9.58. So he's also involved in relay run with his team members for Jamaica as well, and they have completed it like within 36.84 seconds. So if you consider it for each individual, it will going to be really very less than the individual's record. So now, in this world, I think there is nothing else should work than collaborating and working together. It's because the resource, as well as the understanding, the culture and the knowledge that we have in different parts of the world is also diverse, and that is how we can learn one from the other. So that is one best example. So in collaboration, I think we need to have a focused common goal, and we have to understand that collaboration is the source for the completion. So in our collaborations, we set a goal and we define the objective, and we plan action plans to proceed. So this was what we did with some of the collaborators that we have, including Norwegian hospitals that we are collaborating with currently through HPBridge. So in this collaboration, I think a shared and a win-win goal is very important, because it should be bi-directional. If it's going to be one-directional, that will going to become very boring. So it should be a bi-directional collaboration. So I will mention that even though we are living in sub-Saharan Africa with a very limited resource, we do have something also to contribute for the world, and to even to the developed part of the world. And the other one is adaptability, because it's not only the knowledge and the skill that we are going to share. So there is also a culture that we're going to share. So friends coming from the Western, they were very amazed how we are also living also in the hospital as well in the city. So that is also one of the things that people can learn, and adaptability is going to be one of the issues. And the other one is transparency. So there should be a clear agenda, and there should not be a hidden agenda while we are collaborating. That's also the experience that we have learned from our collaboration, and we have to be clear on that. And patience. Sometimes things are not going to move as planned. So it might be very slow. Sometimes it might be also very fast, as beyond the expectations. So we need to be patient, because sometimes the culture difference and everything will going to become difficult to understand. So since we are collaborating from different corners of the world, so people might not understand the cultural background that the person have in the other part of the world. So becoming very patient is also important. So these are one of the other lessons that I have learned in the collaborations. So as a sub-Saharan African country, particularly in a hospital where I'm working, what we need for in collaborations, one is training and education. So capacity building is very important for us, because we are living in a different scenario, so the opportunities are also very different. So even though we do have limited resources, still we are not efficiently using or utilizing those resources due to lack of capacities. So that's one of the things. And the other one is technologies and technology assistance. So that's very important. And if, of course, funding and the like for collaborative research works and the like are very crucial. But still, we'd have something that we can also give to the other part of the world. Like we'd have high volume patients with different types of disease entities. So that which is untouched. So that is something which we can provide. And the other thing is, apart from having high volume of patients, we do have also low labor cost, unlike the other Western countries. So it can be easily managed in countries like mine. So the collaborations can be planned. So we had a planned collaboration like in my hospital. So it was implemented like for 4 or 5 years, and was intended to establish a kidney transplant program. And it is planned because it is a government intention. It's not the professional intention to develop a kidney transplant program. So collaborators were arranged by partners from different parts of actually from US, and people were flying into Ethiopia, and they trained surgeons and nephrologists, as well as the operation theater and ICU nurses. And now we are able to run the kidney transplant program in my hospital independently. So the collaboration can be planned, or it can be arranged like with meeting with people. So our HPB collaboration that we're running now with two hospitals from Norway are arranged through meetings. So someone has come. So in fact, Christopher came to Ethiopia. He came just to assess the status of Ethiopian chapter of HPB surgeons. So we established it like in 2019 with the assistance of Professor Martin Smith. So, but because of COVID, it was the connection and the communication was interrupted. So just after the surge after the COVID pandemic was declared that no, it's no more a problem. Professor Martin has communicated with Christopher, and Christopher came to Ethiopia and he visited our hospitals. And then meanwhile we discussed the way how we can collaborate to each other, and we have discussed, and then we developed at least one project that is a registry program for outcomes, 30 days outcome and 90 days outcome. So I have, if you want, I have a poster on pancreatic adenectomy on this congress. So in that poster, if you see the number of patients that we have operated, that means we did pancreatic adenectomy in my hospital were around 30 patients. But of those 30 patients, we didn't have any information for 11 of our patients after they have discharged out from the hospital. But we do have a few information about 19 of the patients, and it's also for a limited time. That is only for 30 days, so we can't trace them beyond that. So now we have established a registry through this HPBridge collaboration with two Norwegian hospitals, one in University of Oslo, where Professor Christopher is working, and one is in Tromsø, where he have been working before, and we included colorectal surgeons as well, and we started to have a registry program. So through this registry program, we have just started last January, and over 2.5 months, we were able to register 60 HPB patients who underwent major surgical resections of the liver and the pancreas. So now we know how many patients are lost exactly from the follow-up. So yet we have lost only one patient, and we were able to trace nearly 45 patients are alive for 30 days, and I think 9 patients are surpassed 90 days, and the rest 6-7 patients have been in the hospital at the time of the evaluation of the data. So that is one of the success that we do have in this collaboration. So sometimes collaborations can be also accidental. So the collaboration has given us an opportunity to have a bilateral learning. So we have been to University of Oslo and Tromsø. We have seen how their system is working, and we have learned what systems can be copied to and fit to our system, even though the resource availability is different, but still there are something which can be customized and which can be also adaptable to the setup that we do have in Ethiopia. And we have also seen some new knowledge, and and in fact we have also transferred some old techniques which the Europeans and the Americans have forgotten. And I remember talking about segment 3 bypass, even for Professor Martin as well as to Christopher. They told me that they have never seen it. So for a patient with hilar cholangiocarcinoma, since we don't have a well-developed radiologic intervention as well as GI intervention, we usually do it segment 3 bypass. So just we do hepatotomy, look for the duct for the segment 3 and put a jejunum there, and the bilirubin will going to be dropped, and our oncologists will going to be comfortable to give them at least palliative chemotherapy. So this is something which the Europeans and the Americans have forgotten to do, because the technology has assisted them much, but we are not assisted, so we have to help our patients with whatever we do have at hand. So I believe we teach Professor Christopher on how to do segment 3 bypass. And we have also seen how they are doing better. The pancreatic adenectomies, hepatectomies. So we are doing, in fact, yes, but we have to improve our skills, because for the best outcome of our patients, for the best oncologic benefit of our patients. So the extent of dissections, the way how we are doing, all those things which are going to affect the quality of patients. So we are learning also that. That's one of the things. And the other thing, still, it is very important to know or to see the different part of the different phase of the world. So typically, particularly if you see the cancer surgeries, so epidemiologic characteristics, observational, even though we don't have a detailed registry, which we have started already, the characteristic looks very different in our setup. So I'm sure it is very unusual in Western countries to have a guy in the early 20s to have hilar cholangiocarcinoma or intrahepatic cholangiocarcinoma or HCC or colorectal malignancies, which is very common in our setup. And so there is an epidemiologic variation. And still we have also some different biologic natures. So this is what we have seen in breast cancer. In fact, we didn't do it in HPV. In breast cancer, we had a collaboration in my hospital with the American hospital, and we're trying to see the status, the triple receptor status of patients with breast A. And as universally, it is known that 70% of the white ladies are triple receptor positive, and the black Americans are 30% positive. But in our setup, or the biologic nature that we have seen from our hospital was 60%. It's in between the black Americans and the whites. So so there are a lot to investigate. So there is we can generate a new knowledge if we can collaborate. So that is what. So we have also adopted innovations. So I think you see this is a hepatectomy that I'm doing, and we don't have a proper Thompson retractor. I'm sure most of you have that, and I have seen this how our friends were doing it. Years before they do have Omni and Thompson retractor, and we adopted it and we took it to do it without having significant struggle. So we used to use our residents here to act as a Thompson, but this has helped us a lot. So in adoption of innovations and the like is the other thing that we have learned from this collaboration, and in fact we have also shared few resources. So that is the things. So thank you very much.
I know we've had an exciting time. HPBridge gives us opportunity to build family. It helps us to give and build the humanity out of us. It also provides opportunity for us to learn, but at the end of the day, improve the quality of service that we render to our patients. It's time for us to have questions and answers and discussion time. Please feel free to approach the mic if you have questions or you have some comments that you want to give on how we can do this better. Yeah, please.
Thanks very much for the talks. I just had a question for you. As a trainee in the UK, in Yorkshire, I'm an HPB registrar. And I'm a global surgery researcher at University of Leeds. But when I talk about global surgery and HPB, they say that it's not compatible, that you cannot be an HPB surgeon and be interested in global surgery. So why do you want to go to Africa is one of the comments that people make. So it's very inspiring to hear what you've done, and a lot of interest that you have in Sri Lanka are the similar interest I have in India and Sub-Saharan Africa with gasless laparoscopy, which is my research interest. And it's interesting to see some of the retractors that you've shown. So how did you essentially tailor your career so that it allows you to give the time that you need to foster these collaborations? Because I really don't want to end up just doing service provision in the NHS and miss out on this collaboration, because I feel very comfortable in this room, but I don't feel comfortable when I'm at work at times when I talk about global surgery. Yourself or anybody else in the room who has experience. Thank you.
Thank you. Does it? Yeah. Do you want to respond? Okay. Response.
Sorry, my voice is a bit off, so I'll just use the microphone. But I think that's a great sort of question and thought process that I think a lot of people struggle with, and I struggle with. And my feeling is that it just comes down to, it sounds like you have kind of a passion for it, and with that passion, I think you make time. It's difficult, like it's not financially remunerable. It's not something that generally gives prestige or honor or anything like that. But I think if you have that feeling and you make time, what's really amazing is that people will generally come along with you. And there are a lot of people who have similar thought processes, and once that builds, I think you can have a really meaningful collaboration. Yeah. Brendan, do you have any thoughts about that? Yeah.
It's a great question, and there are definitely, in the United States certainly, academic surgeons who manage to make this their shtick, in part of their scholarship. Though typically it is folks who can work on, sort of relatively more easily transferable skills, and then projects accordingly, and then demonstrate that they can help, upskill folks in basic laparoscopy or things that are sort of easily scalable and therefore studyable. And truthfully, I mean, it's something that we think a lot about, of how do we help share HPB skills, which is quite different than what is traditional global surgery, where it's really starting at a higher frequency but lower complexity interventions. For us, where we have these low frequency, incredibly high complexity interventions, and how to help that skill transfer and share knowledge back and forth is quite different. And I think we're starting in HPBridge with the fact that a lot of this is judgment and knowledge sharing. And that there are already actually a remarkable number of very skilled surgeons who just need, by these interactions, I think, there is a little bit of case selection, judgment, and experience from higher volume centers that can be shared to help them turn a corner to be able to offer interventions they might otherwise not. But how to do that, I think, is honestly partly why we're gathering here today, to help figure that out. Like, how can we do this in a way that really is sustainable and meaningful and is positively impacting all of our patients? So I think your question is really the core of why we're gathering and starting to share this interaction.
My few comment to that is, I look back to myself. I go to the village almost every weekend when I'm back home, and that's like my pastime. Why do I go to the village? Because I have a passion to give, and also because I can improve the quality of life of the people that are there. So the same thing I'll bring into this HPBridge. There must be, like he said, a passion from within to give and to change quality of life. But more importantly, to also improve your academic career, there must be built-in research program into whatever is done. Everything that is being done, there should be, like Dr. Wolito talked about the retractor, who says that you can't compare the effectiveness of that retractor to Thompson. Should we be recommending Thompson to all low middle income countries that cannot afford it, or build something that is locally available and draw up a program, a research career? That, of course, at the end of the day, end up improving the career of the people that are giving. If you build in research to whatever you are doing, through the research, grant can come, which will definitely enhance your home profile and all that kind of a thing. Peter and I have been working for more than a decade, and everything, we started with just observational study, but now we have almost about 5 NIH grants that we are working on. Of course, that helps both of us in terms of career promotion and all that. And that also brings promotion. Of course, by the time you have grants, it's easier for you to start making demand that I need time out to be able to face all this. Without such things, it's difficult to convince the institution that you work in on giving you opportunity to commit more time to others. So my advice is that any collaboration that is being established, fundamental of that collaboration should be, how do you design research career that can be both beneficial to both parties? Thanks. Any other comment, please? Please.
I have a question, Suleiman Naji from Canada. I have a question regarding the MDT specifically. I think it's a wonderful, given the geography, a wonderful opportunity to build relationships, to connect, and to share knowledge. But when it comes to case discussion, how are you ensuring that the cases are contextually relevant, that the discussions are focused around recommendations that are within the confines of the resources that are available within the country, to make sure that the conversations are relevant both ways. And as a follow-up, I wonder when recommendations are given or conversations are had around certain cases, is there a mechanism where there is some follow-up to the group to discuss what actually happened? Because I think offering advice from one perspective to another may be based a lot on kind of a more of a theoretical understanding as opposed to an experiential understanding of being immersed in that environment. I think it could be very educational, particularly for the Western surgeons, to maybe get feedback on what actually happened. If the recommendations were enacted, what were the outcomes? Was that a good decision by the board? If they weren't, what were the barriers? How can we overcome those barriers? So some mechanism where the case discussion is brought back to the group so we can all learn on how to improve that conversation towards better patient care by understanding each other's environments better.
Can I suggest, Solomon, that we go for the next session where we'll have 3 presentations on ongoing NDT discussions just like that, and we return to your question afterwards, then maybe that will give also some perspective. Is that okay?
Yep.
Okay, so then we'll go into 3 short talks about bridge programs that have been running this winter, and the first one is Hariharan Ramesh from Lakeshore Hospital in India. Good morning.
Good morning, ladies and gentlemen, Mr. Chairman. I can't tell you how much of a pleasure it is to be here. I've been a member of the IHPBA for over 3 decades and always bemoaned the fact that we did not have formal plans of interaction, collaboration, and learning from each other. We had lofty presentations from the pulpit, as it were, which went down our throats but didn't linger in our hearts. And I believe that this may be just the opportunity for us to bring our thoughts together. I bring greetings from Lakeshore Hospital, a hospital of 460 beds, commissioned in the year 2001. And this is a picture Dr. Jason Thomas, my colleague, took at 7 o'clock 3 days ago from the 8th floor of our hospital, and that's why it's called the Lakeshore Hospital. I'm presenting this case also in the hope that this will not just be a one-to-one interaction, but whole units, whole regions will cooperate, and hopefully this will be the last presentation someone with gray hair like me presents, and there will be more younger people who will take part. So I want to describe the story of this 56-year-old executive who had diabetes mellitus. He was on metformin. He'd already had an angioplasty and stenting in March 2023 and was on aspirin and clopidogrel. He had VDRL positive, and he had syphilis. He didn't know when or how he got it, and it wasn't important. There were no symptoms. He had features of chronic liver disease with cirrhosis of liver and a MELD-8 he was on carvedilol. His alpha-fetoprotein and PIVCA were normal throughout his story. In 2022, November, he had a laparoscopic cholecystectomy for symptomatic cholelithiasis, and when I say symptomatic, he had abdominal pain in the right side with radiation to the back. A month later, he had post-cholecystectomy cholangitis, ERCP and sphincterotomy, and balloon sweep showed only sludge, and a stent was placed, which was removed the following month because the liver function tests and the imaging were normal. However, soon after, he got other episodes of abdominal pain, strangely, and then an MRCP and a CT showed segment 8 dilatation, which was described at that time as a post-cholecystectomy stricture or even a neoplasm. In February, an ERCP and spyglass cholangioscopy was done, which showed a friable tissue in the anterior sectoral duct, some active bleeding. The endoscopist just panicked and abandoned the procedure. No biopsy was obviously done, and not only a stent was placed. The patient had not dropped his blood pressure, or there was no tachycardia, but they quickly referred the patient to the interventional radiologist, who promptly embolized the segment 7 and 8. Further management was, of course, at our center, and he presented with recurrent episodes of abdominal pain in the month of April, vomiting but no icterus. He had the features of chronic liver disease, and his INR was 1.4. A CT scan at that time showed multiple hyperdense peripherally enhancing areas in segment 8 suggestive of cholangitic liver abscesses. And there was a mild intrahepatic biliary radical dilatation with wall thickening along the right posterior segmental duct. Whether that was the consequence of interventional radiology or not was not clear. And there was, of course, the biliary stent, and that could be another contributory factor. He was given intravenous antibiotics. The stent was removed in June 2023, and a week later, symptoms came back. Again, ultrasound seemed to suggest cholangitic abscess, and an MR-MRCP showed, as you will see, this series of pictures, and I'll comment on them at the end, that the segments 7 and 8 have actually been embolized and rendered indistinct in a way, but there is some thickening of the biliary radicals in those segments. And the right lobe itself was atrophic with crowding of the right lobe ducts. It was obvious that we were dealing with a right hepatic duct stricture with cholangitic abscess in segment 7 and 8, and the question was what to do next. Our endoscopy colleagues decided to repeat the digital spyglass endoscopy in 27th of June, and they found a complete block of the anterior sectoral duct by a mass, and biopsies showed atypical cells. The family was counseled for a right hepatectomy, but they had lots of questions and doubts, and therefore the endoscopist felt a repeat cholangiscopy was justifiable. But that showed, the biopsy showed poorly differentiated adenocarcinoma. The patient then went ahead to have right hepatectomy on the 20th of July 2023, and stricturing growth was seen in the segment 8 involving the right hepatic duct, 1 centimeter away from the confluence. All the margins were negative, and there were enlarged perihilar lymph nodes and HDL lymph nodes. Frozen section was negative. The histology showed a right hepatectomy specimen showing poorly differentiated hepatocellular carcinoma. The lymph nodes were uninvolved by tumor, and the histology was confirmed by immunohistochemistry. The critical issues that I realized is that this is one example of how resources or the availability of resources need not help the patient. The person had background HCC and had a problem with a right hepatic duct stricture, and it would have been perhaps better to reflect rather than to intervene so quickly. What could have been done at the first instance? Could we have done away without embolizing in the first place? And considering that HCC with bile duct involvement of this type is uncommon, can we have some tricks to improve diagnosis? And is there a role for primary or salvage liver transplantation? After all these questions, I'd like to listen to your thoughts. Thank you very much.
Okay.
Yeah,
I think we'll go on to the next.
Yep.
And we'll do the questions in the end.
Keep over.
I wonder whether there will be loss of connect with this case if we waited to the end.
We will have some time for questions in the end, yes. So we will go on for the two other presentations of the discussions that have been going on this winter. The next one is Joseph Besabi from Harare in Ethiopia.
So we can keep our response to the case that was just presented till after our case presentation. Then we'll discuss everything as they go.
Good morning, everyone, and it's always a pleasure to be in this podium. So I would like to present what we have discussed in our HPBridge. So I have nothing to disclose. So this bridge, when the call came in June and July, I was excited to apply on behalf of my institution. I was a fellow that time, and so when we get it, it was very exciting to be involved with University of California and University of Oslo. And it encompasses also in Addis St. Paul's Hospital and as well as our institution, which is Addis Ababa University. So far we have had 3 sessions, 3 MDT sessions, and we have discussed 4 patients, and we have also presented 1 survey result, which was looking for the hepatobiliary surgical workforce in Ethiopia. So I will go on the case briefly, which was presented, one of the cases which was presented in the MDT session. So there was this 22-year-old female. She had epigastric abdominal pain and pruritus for 1 month, and she had also features of obstructive jaundice. So she had pruritus and stool urine color change, and as well as yellowish discoloration of the eyes. So on exams, she was chronically sick looking. Her performance was 1, and otherwise her vital signs were stable. And she had icteric sclera and scratch marks all over her body. So we did a preoperative scan, and there was a preoperative investigation, and she had leukopenia, and she had her platelets were low, and bicytopenia was there, and her bilirubin was very high and was direct of 13.5, and the total bilirubin was 26. And also the INR was raised, and viral markers were negative, and abdominal ultrasound showed there was peripheral cavernous transformation around the colodocus. So we did also a scan. So this was the scan. So in the axial scan, as you see here, there was the bile ducts were dilated, both intrahepatic and extrahepatic biliary trees were dilated. There was significant splenomegaly in the coronal section, and so she had also a portal vein thrombosis of the main portal vein, and the splenic vein were dilated, and there was a huge splenomegaly. So, and there was also, I'm not sure whether it's visible here, there was extensive pericolodochial, perigastric, and that of periesophageal extensive varices. So she had obstructive jaundice with pruritus, intra and extrahepatic biliary dilatation secondary to a portal biliopathy, bicytopenia secondary to hypersplenism, and she had chronic portal vein thrombosis. So this patient was not presented as a pre-op case. She was operated, and she was discussed for educational purpose. So and to know the perspectives from the high income setup. So the intraoperative finding was there was a perihilar cavernoma, and the CBD was significantly dilated. The spleen was enlarged as it was seen in the image, and congested liver and dilated vessels all over the abdomen. And so the splenic artery and the splenic vein were identified, and this is what the surgeons did in black line. So the splenic artery was ligated. They did splenectomy, and they did splenorenal shunt. So it was not difficult to touch the bile duct that time to do any bypass or any sort of thing. So they did a splenorenal shunt. So immediately the patient was transferred to the ICU, and she started on SIPS on the second post-operative day, and took peripheral TPN because there is no available TPN, total parenteral nutrition, which is centrally given in our setup, and she took only peripheral TPN. So she was on oxygen. She stayed in the ICU for 6 days, and she had extensive ascites, and it it was frequently tapped later when they put a percutaneous drain, and she was, after staying for 3 weeks, she was discharged from the hospital. So currently she had a postprandial discomfort, minimal ascites, and jaundice, which has resolved currently. So why do we present this case? It was unique case, and most of, had this patient been in the ideal setup, the story was different. I mean, she could have had ARCP and stenting for the jaundice, and she could have been managed with interventional radiology like TIPS and the like for the portal hypertension. So we want to have a perspective of what happens if the setup is ideal, or what we have done was right, or what should we improve was one of the things we have discussed in the session. So what we have learned was resource-driven solution was there, so limited RCP availability. It was even, it's available in the country, but it's in the private setup and it's unaffordable by most patients. So, and our IR is limited to few procedures, and it's hard to manage this patient. So, during the MDT, there was a comprehensive option assessment. So even if it is a post-operative case, so it was discussed as if this patient was preoperatively discussed. So everyone was contributing, and we were discussing the options. So that was a learning experience for us, and it was instrumental. And enhanced perspective and diverse insights and holistic approach were there. And so there were constructive feedbacks to the surgeons who have operated, so that is encouraging for us to look deep into our options and to explore our other options. So, and it was addressing our disparities. We have seen the disparity between the Western setup and our setup. So even if our actions were right, but they were not ideal. So we have to strive to bring the purpose of the bridge is to give, access to HPB surgery worldwide. In terms of bringing access for everyone to have the best care. So in terms of that, the bridge, bridging the gap between HPB care, especially endoscopy and minimally invasive surgery, is important, I believe. So the professional values we had was, there was a learning opportunity from experienced surgeons, which goes beyond our technical knowledge. It was instrumental for us, and gaining practical knowledge on how to approach and interpret cross-sectional imaging was very important for us. Enhanced problem-solving abilities of the surgeons. We have seen there weighing different factors, considering the differential diagnosis when we discuss on the cases was very important, and it had an inspirational impact. So witnessing successful outcome and overcoming challenges. Of course, this MDT has its own limitations. So I would say it's difficult to wait for 1 month to present a case. So you cannot keep the patient 1 month to have a discussion. So if luckily we had present also one preoperative case, and it was very important for us, but it was recently, we couldn't prepare it for the bridge. And so it was one of the challenge. So it's always important to have this collaboration. We need to scale it up for the future, for exchange programs. So like my colleague and my mentor said, Dr. Wulatau, so we have had also something to offer. So you need to send your residents to learn open cholecystectomy. So still we are doing, in your setup, I know that 98% or 90-something% of cholecystectomies are laparoscopic and the like. So we are doing almost half of the cholecystectomies in open way. So there is something to offer from us, and you need to teach us some of the advanced skills in HPB surgery. And I would like to conclude and thank you very much.
Thank you. So we'll also wait with the questions, and I think hopefully that we can focus our questions on how this bridge can be used to learn from, but also, of course, if you have questions directly to Dr. Ramesh's case, that's also, of course, possible. Now for the last talk about ongoing bridge program, it's a pleasure to introduce Jose Contreras from San Carlos University, Ciudad de Guatemala.
Good morning. First, I want to apologize with you because I just landed to Cape Town and my luggage is in Johannesburg, so I don't have too much time to buy another dress, so sorry about that. And sorry for my English, this is still in progress, but it's a very pleasure for me to be here, and I want to thank you to all people to collaborate with me. And so I am going to present a case from Guatemala. Guatemala is in Central America, to the other side, to this part. We are about 18 population. So I don't have this flash. Yeah. This is part of MDT group of HPBridge. As you know, I'm Jose Contreras. I am an HPB surgeon from Guatemala. I work at General Hospital for Disease in Guatemala Social Security Institute. This hospital is a reference hospital in all the country. So we receive all patients who have social security. So because the time I'm going to continue with the case, this is a 36-year-old male who was referred to abdominal pain and jaundice since 2 weeks ago. The patient didn't have other history. And in a private hospital, they perform some different studies. They perform ultrasonographic and resonance of bile duct, and they found extrahepatic bile duct dilation with narrowing of the distal common bile duct and mass in the head of the pancreas of 2 centimeters. Do you remember the patient had 36 years old? So they performed 2 ERCP, but they reported it's not possible to granulate the bile duct due to the presence of the extrinsic mass. So they decided to refer to us or to our hospital, and we performed the CT scan. This is arterial phase, and you can see the patient has mass in the head and the neck and part of the body. This is the coronal phase. And we can see, sorry. Okay, I'm going to continue with that. This is the portal phase, the phase of the CT scan. As you can see, the patient didn't have other lesions or metastases, but had a very important mass in the head. This is the coronal phase. And as you can see, there is a part of the mass in the confluence of portal mesenteric. There you are, there is a picture. And the patient had narrowing with the mass. So this is an important part of the presentation because the patient had 2 arterial variants. As you can see, the right hepatic artery comes from the superior mesenteric artery. So we decided with our group perform surgery. We decided to perform in this moment a pancreatoduodenectomy. I am going to explain some topics then. So in operating room, we found a hard pancreas with multiple irregularities from head to tail, and pancreatic duct from 4 millimeters, and the neck of the pancreas was attached to portal mesenteric, portal vein and superior mesenteric vein less of 118 grades. So with that, at this moment, we performed Whipple. So, but with other partners or colleagues, we didn't feel comfortable with the pancreas because it's hard. It was hard. So this is a picture and compare with the studies. Let me see if the video runs. Oh, I think no. Oh yeah, you are. So you can see the portal vein and mesenteric and correlationate with the CT scan. And this is the arterial variant. And this is, we perform the vascular resecting, and we perform the primary close. So, at this moment, we already performed the pancreatoduodenectomy with partial vascular resection of the portal mesenteric confluence. But this is picture of the pith. This is the body of the pancreas, but at this moment, with my colleagues, we didn't feel comfortable. So we decided to send to our pathologist margin, and at this moment, they reported that they still tumor with adenocarcinoma. So we decided to extend our resection of the body, but they still reported that adenocarcinoma in the body. So what now? Now what? At this moment, I would like to call or present this case in this session, but that is impossible because I am in the operating room. And with my college, we are deciding to what is the best option for this patient. Remember, the patient had 36 years old. So we decided to perform a total pancreatectomy with the splenectomy, because the arterial spleen are involved, and performed to do reconstruction with a gastrojejuno anastomosis. And final pathology reports that the patient had neck and body ductal adenocarcinoma well differentiate with the lymphovascular invasion and perineal invasion. So the patient stayed. It was about 7 days, and the follow-up, the patient goes to endocrinology for treatment for diabetes and exocrine pancreatic insufficiency, and with oncologists to receive the chemotherapy. This is part of our MDT HPBridge meeting with a college from MD Anderson, and I am going to continue with that. Our experiences of HPBridge, you know, with my case, maybe you think the best option was chemotherapy first. So it's important to me that you know, in countries like Guatemala, for the patient, it's very difficult access to treatment, especially in chemotherapy first at the surgery. So our group decided perform first surgery and then send patient to the oncologist to receive the chemotherapy. This is part of that is important for me for be present here and be part of this kind of group, because many I don't know, maybe some surgeons for in our countries or I don't know, thinks that they don't have opportunities to collaborate or to meet professors in other places of the world. But that is false, because I am here and maybe the language is difficult or money is less, I don't know. But for me it's very important, because when I am going to return in Guatemala, I am going to show them the photographies and I am going to say, look at me, I am in South Africa and I am presenting a case from Guatemala, so that is possible. So this is part of great for me and great opportunity to know all of you, and please I want to thank you. And why I shared this particular case during the HPBridge MDT, because I think this is a difficult case, because the age of the patient is young, so that is a difficult case, and I want to hear you if you maybe take a different option for this patient. How the MDT affect the subsequent care for this or the patient? That is that I mean. I am going to continue to show in my country the importance of that of this kind of decision, because it's important to our patient receive the best treatment, and I want to show to my authorities in my country the importance to access to chemotherapy treatment first at the surgeries, for instance. Care learners take away from my experience of HPBridge, so that is that I mean. And where HPBridge adds value to my practice professional life, you know, I want to show my residents in my hospital. My hospital is a academic hospital. I have a residence from surgical. So for me it's very important to show them that we have opportunities in the world to collaborate with other people. And please visit Guatemala. This is some part of our country, and this is some members of our Guatemala chapter from HPB. So thank you so much.
Okay. All right. One thing that most of us take for granted, especially some of us in the West, is that when you have issues on the table, you can call the next room. I've been to MSKCC, Peter called, Mike, Angelica, come over and see, call others to see. Most of us that practice in low middle income country don't have that privilege. When I started with Peter, one of the things that I brought on board is real-time decision making. Fortunately, Monday happens to be my theater day, and he's in the clinic. He's not operating, so he can pick his phone. And many times I have to call him, come on, please, come over to Nigeria on phone. I have issues similar to what you had, and how do we deal with this? And it has been helpful. But HPBridge now expand that horizon for me. I have Aaron to call, I have Gabriela to call, and so it's been wonderful, no doubt, having HPBridge, because it actually enhances our practice and decision making, real time. we can take decisions. Sometimes we can't wait for a month, like he said. We have a WhatsApp group. I share the video. Please, what do you think? And that has been very helpful. I'll be operating a patient next week, and I felt that, okay, I think I know what to do, but I'm not very sure. And I send it to the group, and lo and behold, a lot of comment. So it's been wonderful being part of HPBridge. So I don't want to take all the time talking. I know we have questions, and you have suggestions, and we need response to some of the comments that have been made. So please, the floor is open before we have the last talk with Peter.
I'm Sudeep Shah. I'm a surgeon from India. I must congratulate all the speakers. And I must say that I'm very sad that this is a small session early in the morning. This should be for the whole Congress, especially when it's in sub-Saharan Africa. I come from an LMIC country, and I sympathize with all the people here. To take a continuation of the last question we had in the previous section is how do you, approach technology across countries? We'll find that in Ethiopia, your problem is the same as we have in India. We call it portal cavernoma biliopathy or portal biliopathy. We have a national guideline on this. So if you see the Journal of Clinical and Experimental Hepatology 2014, it's free online, it's an open access journal. You will find a complete guideline on the management of this condition. So maybe, though we are an LMIC country, we might be more helpful than Memorial Sloan Kettering or MD Anderson for this condition, because we see, and I personally treat maybe 3 or 4 of these every year in my center. So maybe we can have a discussion outside. I don't want to bore the rest of the audience on what you could have done differently. But there should be a forum where his problem can come on the HPB mailing list and say that who can help you, because it may not just be a small panel of people, because we represent, I think, 130 countries in this conference. And another comment I would like to make for the gentleman from Guatemala, that if you do ask MD Anderson, even if you had a 1 centimeter tumor in the head of pancreas, they'll say give neoadjuvant chemotherapy. We know that, that's their publication and that's their data. So maybe, when you come from a country similar to mine, and FOLFIRINOX is more likely to kill the patient than Whipples, you need to be a little careful in an undernourished, icteric person in what you're really doing, especially when they're from a lower socioeconomic class. So again, I think that guidelines have to be read in the context of the countries you come from. And maybe we need to have separate guidelines which take the ABC, the clinical condition of the patient, the anatomy as well as the biology, and not just an absolute guideline that this is the best way forward. And often you find that, and I trained in the West too, that they don't understand a lot of our patients. And when they get patients like us, in the UK, for example, 15% are from an Indian or Asian ethnic background. And amoebic liver abscesses come when they travel back to Gujarat for a holiday, they drink the water and they come back. And I've seen them being diagnosed as hepatocellular cancer because the imaging is exactly similar. So it is a two-way thing, and I think all this needs to be integrated. So that's my 2 bits. Thank you.
Hear, hear.
Other comment, please.
Yeah, so a question. So ultimately, Yosef's case is an amazing one, because it illustrates how we are de-skilled like a segment 3 bypass. So we had a case like that at Stanford. GI did an ERCP to drain the jaundice, but they did a pre-cut, which caused exsanguinating hemorrhage. Then asked me to come down and stop the bleeding, and I said, "There's no stopping this bleeding by a surgical means this time." So then I said, "Put in a covered stent, put it in a balloon, leave it up." Went up to the ICU, and then we ended up doing a splenectomy and a splenomegaly shunt. And I'm the only one at Stanford who's done one in the last 10 years, and I've done about 3 of them, because we are so dependent on IR to do shunts. So I was the only one who had some kind of historic knowledge, because none of the transplant surgeons at our institution have ever done a splenomegaly shunt, which was the only solution because there's not an interventional radiologic solution. So we have de-skilling now because we have become reliant on technology. And so what you did, ultimately, obviously doing it in the setting of jaundice it made a slower recovery for your patient. But from my perspective, a splenorenal shunt was a terrific solution and something that I think we would have struggled at many U.S. and European centers to deliver anymore because we've been de-skilled by reliant on interventional radiology.
More comment, please. As regard, please, go ahead.
Hi, morning. Karan Gandhi from Kenya, Nairobi. I think for all the speakers, it's fantastic to see that we're all kind of in the same boat with the challenges that we face in terms of patient management and what our resources limit us to do. I think one of the biggest things that's in the HPB world is endoscopic ultrasound, and in Africa, I think majority of us do not have access to endoscopic ultrasound, and it's been a complete game changer in terms of the diagnostic, the interventional modalities that we can actually do with endoscopic ultrasound. And I think some of the cases that we have here highlight that very easily. The segment 3 bypass that we're speaking about is now done through EUS into the stomach. They do hepatogastrostomies through EUS. So we'll probably get there at some point in the next decade or so. But I think the challenges that we face in our setting are real. I would just like to know maybe from Yosef about the patient, like post the splenorenal shunt. Did the jaundice actually settle, or is the patient still jaundiced? It's just interesting to know. And what is the cause of the portal biliopathy in your case? Is it more of schistosomiasis that you see in your setting, or is there a cause that you treat that as well at the same time?
Actually, this patient was operated by my consultant, Dr. Zaki. So I would like to acknowledge that. And I was in another institution because I applied for the bridge. I was involved and it was a learning experience. So the jaundice has settled because the cause of the jaundice were the pericholedochial plexuses, and that was the pressure applied on the bile duct. So after the shunt, the jaundice has settled, and there was portal vein thrombosis, and we don't know the cause. It could be previous pancreatitis attack. I don't know. It was not that investigated. And of course, there is schistosomiasis. Is very common as cause of portal hypertension, and most of the time we offer them devascularization. So most of our patients, I mean, there is no devascularization surgery, I'm sure, in your setup, so that's what we offer them. But what makes this case different was there was a significant raise in bilirubin, so this patient was treated differently for the jaundice with shunt.
Thank you. I happen to have operated on this patient. This was a patient, a young lady with portal biliopathy secondary to HPVO. She had extrahepatic portal vein obstruction. Otherwise, the liver was normal looking. It's just extrahepatic portal vein obstruction. She had bilirubin of over 20 and hypersplenism as well. So we had to address both on the same go. We usually do devascularization procedures. We don't do shunt a lot, but in this case, devascularization wouldn't help decompress the biliary tree. So we had to do proximal splenorenal shunt with the splenectomy. She had a very rough course because she was malnourished, very debilitated. She came in advanced condition, a very bad condition. She had some rocky post-op course, but the way the bilirubin dropped, she actually became non-icteric within 10 days from bilirubin of over 20. So she didn't have the fixed components of portal biliopathy, luckily. So it was just the reversible causes. Thank you.
Thank you.
Thank you. That was a great job, operating a patient with thrombocytopenia, leukopenia, and elevated bilirubin, and getting the patient out of theater. I think we need to give you a round of applause.
Somasundar, I'm from Rhode Island, USA. I think all these cases were excellent presentations, and one thing is access to care. And in case of Dr. Ramesh's presentation, not only was there good access to care with ERCP and spyglass and everything, the question was, are they doing the right thing? And how do we educate these people who have intervened earlier, and then maybe the intervention was not the right thing to do at that time, and what was it how do we educate these people in the future? In terms of total pancreatectomy, how do we manage them postoperatively? That is a bigger issue than even doing the surgery as such. Mm-hmm. So I think those are things that we need to address also. It's not only surgery, but I think the preoperative setting and the postoperative setting should be really looked into and applied appropriately. And I think the bridge should just not be about surgery, but I think also the postoperative setting and the preoperative setting.
Thank you. I will also comment as regards Dr. Suleiman's comments. As much as possible, the people that are making comments, you understand the context with which the people are practicing. It is very easy to say, no, that's not the right practice, but you don't know the setting except you are there. So as much as possible, what we advise and the benefit we've had with all the people in our own HPB group is that they have in their brain, behind their mind, that they are not in Israel, they are not in France, they are not in Slow-Ketri Cancer Center, they are in Nigeria, and the setting is completely different. So that's we set across to everybody, and then the next thing is to be able to do the best for the patient. Initially, we were doing post-op cases, but now we've moved to pre-op cases because that's what we believe will help better in taking decisions. Should this patient go to chemotherapy first? Should this patient go to surgery first? What type of surgery is this? And I believe almost all HPB groups has gradually continued to mature into that. You need a champion on the other side that really understand the system and that can also help to bring a change. Everybody in HPB group wants the group they are working with to also grow along with them. And you need a champion, like he said, that is interested in bringing a change locally. The system is different, but you can still achieve the same results with little resources in whichever location that you find yourself in LMIC. And that's some of the things that I believe HPB group should be aiming towards. How do we ensure that if the morbidity following the surgery is 5% in US, should also be less than 10%, if not 5% in wherever we are practicing. And that we can all achieve. HPB group give us that opportunity, and we continue to exploit that.
Thanks for some really great comments. One of the themes that came up here is, I'm from Sloan Kettering, and the goal for this is not for Sloan Kettering to be dictating care somewhere else. If you want to read about how we approach patients at Sloan Kettering, you can search in PubMed, there's plenty of papers. We tried to be very conscious in making these groups to have broad representation, and in a little bit at the end, we're going to put a QR code up. So anybody who's not involved, who's interested, please put your information in, because the goal here is really people from lots of different regions, like we're doing in this room here today, realizing how similar problems are, and to brainstorm about solutions. And to give an example of, Suleiman asked a question about what's the follow-up, and we're still learning how to do this correctly, I would say. Hopefully we get some ideas from today. But on our WhatsApp is something we use commonly, but from just our group, Isaac showed a case from a patient who he thought needed an ampulectomy. Aran, on his way here, stopped off because he had just done an ampulectomy and was showing the video online. So Aran from Israel stopped in Nigeria, They did Isaac's first ampulectomy, and that was all within like 6 weeks of the case being shown. Now, that wasn't planned, but that's just sort of an example of how organically we're hoping out of these groupings, relationships like this form, and something that's presented in an MDT forum, there can really be an assistance with acting on those patients. But we really appreciate all the comments and the themes that have come up. Thank you.
Please, sir.
Thank you very much. Good morning, and very good presentations. I'm happy that the gentleman who spoke before Peter raised the issue of post-operative management. Arising from that also is a crucial judgment on when to proceed and when not to proceed. If we took the prognosis of the condition into consideration before making the decision on whether to go ahead or not, then maybe if the guy from Guatemala saw that management of post-total pancreatectomy in Colombia or in Guatemala will give the patient a worse outcome than if he did something else, something more minimal, or even if he left the patient alone. That must be a considered option in resource-deprived environments. So while we improve our skills to do more complex surgeries, and while we continue to spread the skills around the world, we must continue, as both Peter and Shegun said, to consider options within the technological base of the environment. The patient who had total pancreatectomy may not be able to survive outside the hospital in Guatemala. And in most of resource-poor countries where there is no insurance, and from the experience from Ethiopia, out of the patients they operated, beyond the 30 days, many could not be traced. How do they survive? So the options for surgeries must always be considered with the opportunity for the patient to leave after he has left hospital. Thank you.
Thank you. Okay. Excellent comments. Thank you. Yes, you were actually, your questions were answered. Please.
I think just to follow up on the comment made by a colleague from India, I think the importance of the South-South collaborations in this, right? Because it's great to talk about what can you do in your own environment and what would be ideal, and through that process identify priorities and gaps in care and try to enhance the skills that are available and resources that are available. But more importantly, I think, despite the heterogeneity between LMICs, the barriers and the challenges are often very common. And the importance of having that discussion between countries in similar situations and bringing about the ingenuity and the creativity and the prioritization to get beyond these challenges, I think, really is a really important part of this this partnership. So I think the South-South piece is fantastic, and the comprehensiveness of the group conversation, I think, really adds to the richness and the creativity of this.
Thank you. Excellent remark. We will stop now. We will have two more talks before we finalize, and then we can use the last minutes for more informal discussion here, but make sure we keep the time. So it's a pleasure to have the next talk, a qualitative look at international collaboration across surgical settings by Betel Ibrehu of Toronto, Canada.
I'm very excited to be sharing our qualitative research looking at what goes into building effective global surgery partnerships that do not have any disclosures. As we've kind of alluded to and probably are familiar with, there is a pretty significant disparity in both the incidence and outcomes of HPV disease across the world, and the causes are multifactorial. Just a few to highlight are obviously varying differences in the prevalence of risk factors, including hepatitis infections, the difficulty accessing an HPV-trained workforce, and then also post-operative outcomes for these patients, as we just kind of heard in the discussion, being very closely tied to the hospital infrastructure available to support them. And so understanding the existence of these disparities and recognizing partnerships as a tool to mitigate or improve them, IHPBA undertook the creation of HPBridge, and we've heard from our other speakers some of the ways in which these partnerships are being used to address global health disparities. But prior to the launch of these initiatives, they undertook this research project, which basically was designed to answer the question, what makes international collaborations in HPV surgery robust and effective, with the goal of using this information to inform the development of HPBridge. So we undertook this project by conducting a series of one-on-one interviews with stakeholders who are specifically proceduralists, involved in international collaborations prior to HPBridge, and used the verbatim transcripts for a thematic analysis using a 6-step approach. When we look at who we had participating, we had a pretty good geographic spread, so all but one of the WHO regions of the world, and 17 proceduralists were interviewed, so that's 16 surgeons and 1 interventional radiologist. There were 12 men and 5 women, and more than half were from low and middle income countries. And the theory or the questions that we got, we can kind of take in a step-by-step order. First, by answering why. What motivates people to get involved in these partnerships? And this quote summarizes the motivations quite well. We need to make sure that we are really contributing something good to the future of hepatopancreatobiliary surgery. And to make sure that the minority, the left out, the countries, the units that are left out on the fringes will be helped and will feel that they belong. This sentiment of not only wanting to improve patient care around the world, but also create a community amongst HPV surgeons and care providers was echoed by many of the people who were interviewed. With respect to how these relationships are being formed, we saw that there were 2 broad categories, formal and informal partnerships. So the formal being things like fellowships, visiting professorships, conferences, training courses, and the informal being of rising popularity after the pandemic, things like the WhatsApp group that was mentioned, phone or text discussions, Zoom or online multidisciplinary meetings, and these added a much needed element of flexibility to how relationships were structured. And so we know the motivations and the modalities for these partnerships. We can begin to use the thematic analysis to understand what enables success. And so we had 3 key themes emerge: resources, experiences, and networks. So we unpack it a little bit. So with resources, obviously having access to more time and money can make you more able to build relationships or get opportunities to build relationships. But it very specifically also meant having partners who understand the resources that are available to you, and how that creates a much needed context for what you need and also what you're capable of doing, both from both directions. With respect to experiences, people are very impacted by their global health, their global surgery partnerships, and that's for better or for worse. So having a positive experience can make you more likely to seek them out in the future. And in the best case scenario, a negative experience can inform you what you don't want to do in the future. And then with respect to networks, having early access to a community of mentors, mentees, people to build those partnerships with can be a huge deciding factor in what you're able to accomplish and build, particularly if you get that experience early on. And we saw that these 3 kind of pillars, resources, experiences, and networks, were related. So, for example, if you're given the resources, so the time, the money, the sponsorship to attend a conference, you're more likely from there to have the networks to then build a relationship. And that experience can be much more positive if the person that you're partnering with has the information to understand what your context is. And that might lead you to be more willing to form a relationship in the future. And so when we look at that, the enablers of success are symbiotic. And if we were to summarize, your resources define your needs, and your partners need to understand them. Your experiences are continually shaping your existing relationships, and those you will seek out in the future. And your networks define the experiences that you have access to. And so we take it back to HPBridge, and we ask ourselves, and also our participants, how can we apply these insights? And we got a variety of both tangible and intangible suggestions. So starting with the tangible, we saw that from the early career perspective, people specifically wanted more access to longitudinal, so not just a few month-long fellowship or training opportunities. They cited that for people in their mid-career, there should be ways for them to remain or to get engaged through things like master classes, new or refresher skills courses. And then there should also be opportunities for surgeons from high-income countries to have training about the realities of delivering care in low and middle-income countries. And I think this highlights, thinking of our enablers of success, specifically increasing access to resources and awareness of your partner's resources, and then also creating opportunities for networks. Thinking about the intangible skills, these are the traits that were mentioned by our participants. Bringing things like sensitivity, humility, authenticity, honesty, mutual respect, creativity, and approachability to your partnerships were thought to be key factors, key traits that create a strong foundation for success. And if we hear directly from our participants, quote, I think it's really important to know that those people in lower resource places actually have as good technical skills as we do. We're not there to teach them how to do surgery at all and to say, this is how you should do it. What we're trying to do is explore, to facilitate it rather than us telling them what to do. First and foremost, IHPBA needs to be genuine. They need to be truthful in the sense that they really want to do this, and not just in papers, and not just for publicity. Because there's a tendency for associations, for societies, to do this, and it just doesn't move things forward. So these intangible recommendations speak to what people feel is required to make experiences positive, those traits that are needed. And so going back to the central question of the research, what makes collaborations in HPB surgery robust and effective? We've identified areas for impact and success. For our resources, yes, increasing access to resources, but also that mutual understanding of our partners' constraints and specific needs. Experiences, prioritizing not just the productivity of the relationships, but also ensuring that people are having positive experiences in them. And then for networks, increasing formal and informal opportunities or platforms for relationship building. And as we kind of move into the next stages of expanding this program, we can challenge ourselves to say, how can we use this information that I've presented to guide the expansion? How can we incorporate what we've learned from this into our program evaluation? And how can we make sure that we're reaching as many people in as many different stages of their career in programs like this as possible?
Thank you very much. So we'll move on to the last speaker, that is Peter Kingham, who will wrap this up now in 10 minutes. And while he's moving to the floor, just on behalf of Isaac and myself, want to thank you for this excellent session. Thank you for all the comments and questions. I think we are seeing the beginning of something truly fantastic here, and looking forward to bring more people on board and to use all the comments, creative comments we've had here. Thank you very much.
Yes, thank you all for coming out for this early morning session. This has been in the plannings for a long time. I want to thank two people. Martin Smith was here before. I know he had to leave. Martin, as head of the foundation, has been extremely supportive in trying to fund some of this work. And also I want to thank Lisa Yarrow. Lisa, raise your hand up back there, please. So Lisa from ACS has really been the glue helping coordinate all of this. And it's not just a job, this is clearly a personal passion, and we really appreciate all the effort you put in. There is a QR code up here. If you link on that QR code, you can put in your name and your information if you're interested in HPBridge and you're not a part of it currently. Our goal originally, and this really came from Mihan thinking, we have this collaboration in Asia. Can this grow and can this become something larger in the HPBA, in the IHPBA? And the goal was really to figure out, is there a way to formalize this? So they have a successful collaboration. This exists in multiple parts of the world, but how can an organization like the IHPBA help formalize this so it isn't just a one-off trip or a one-off conference, that it's something longer term? One of the goals for the future, in hearing what people are envisioning for the future of IHPBA and through the foundation, is to try and have more harmony across IHPBA efforts. So for example, as pilot grants go out to junior faculty members, some of them could be steered through HPBridge groups. As travel grants are given out, this year we had access to 1 travel grant per group, which was fantastic, and we look forward to more support like that to ensure that all groups are represented well here at the conferences. But I think that some of the themes that Betty just showed really stand out, things like mutual respect, and we've really tried to build that in and set that as the tone. We are definitely learning about how to take this forward. We've already heard some great ideas and themes today, and we really wanted to use this opportunity to try and bring all of us together who have this common interest to continue to hear your ideas. So I want to thank you all for coming out, and we want to open up the microphone now to hear any other comments and thoughts that you may have about your ideas on how HPBridge can grow and meet more needs of IHPBA in this community. So thank you.
Thank you very much. So this IHPBA bridge was very instrumental, and it helped me to explore options not outside of Ethiopia in my setup. So being away from the center, I didn't know this surgery was offered. So now I'm cognizant that this surgery could be done, and it helped me. I heard this case through the bridge. So had there not be this bridge, I would have not had the chance to know about this bridge. So I want to have few comments. So thank you for it again, and also to hook up us with people who know our setup. Chris and Professor Adnan, they already know our setup, and that was very important for us. So the question for the future is there any plan to incorporate other subspecialties? Because I know in your formal MDTs, you incorporate endoscopists, IR subspecialists, and the like, and oncologists. But in our MDT, it was only HPB surgeons that were involved. So is there any plan to incorporate them? Because this is I believe this is very important to have an all-rounded discussion during our MDT. The other is sharing resources, starting from small clips that we are lacking. So is there any plan to share some resources? Because I was working away from the center, I had to set up a laparoscopy, even simple laparoscopy, and there was no gas, there was no carbon dioxide. I had to go to a beer factory, a brewery, to fill the tank for the carbon dioxide. So resources are scarce. So what is the plan in terms of sharing resources? Thank you.
Great comments, and as I said, this is we're early on in the growth of HPBridge, so these are things that we will bring back to the groups, but there's also group specific as to what the goals and the needs are of each of the groups. The idea of having non-surgeons join the MDT is really group specific. I think it's a great question. I always say Isaac is the most experienced true surgical oncologist that I know, because he also is the medical oncologist and treating patients with chemotherapy. And so there are a lot of people bring different skill sets even from the surgery side, but our hope is these MDTs grow and continue to expand.
This was a really inspiring session today. And for folks separate from just wanting to get involved in ongoing collaborations, we're really keen to get ideas that will help move the project forward and figure out how to sort of flesh it out beyond where we're starting with these MDTs. So for example, and it is evolving actively. So as Peter mentioned, we're working with the foundation to establish some small research grants that would be available to bridge participants that would help figure out some collaborations with small seed monies that would be supporting particularly the low middle income parties to be able to participate in a research project and get started. And a thing we have been grappling with was a question that was asked earlier, which is how do we get some longitudinal information about the impact? So we're sort of figuring out, like, do we have a REDCap database where the cases that are presented are put in so we know across the groups what are the cases that are being presented, and then ultimately get some feedback about what is the outcomes, what impact it is having for those individual patients, and so that we ultimately are learning as a society and all the participants across the different sites. So figuring out, like, REDCap, what kind of data do we need, who can maintain that. So ideas and participants who are interested in engaging, we would love to get you on board because there's lots of folks with ideas and we need those ideas. How to translate it to next steps, say, well, beyond resources, what about specific transfer of ideas and skills and techniques? Do we have a repository for video resources that are relevant for these sort of specific collaborations? So, we don't need a video about a robotic Whipple with vein resection. What we need is some narrated content for transferring skills for specific, accessible, open operations that are not requiring a ton of resources, but have those tips and tricks that sometimes are not included when it's about skill transfer for lower volume surgeons with great technical skills, but little experience with a specific operation that is less commonly performed in that environment, and how a narrated video might help move them forward to be able to actually do that beyond searching YouTube and kind of the poor quality content that's a very mixed accessibility. So all kinds of ideas like that are very welcome as we try to flesh this out and really grow this.
So just had a couple of comments. I think it's been an excellent discussion session around HPB and global surgery, and as I said, I really feel at home. I think as an HPB community, we need to go in line with what the Lancet Commission on Global Surgery have put out in 2015. So access to surgical care, so to our access, yeah. Specialist workforce. I found out that, in Zambia, we have the first HPB surgeon who started working in 2023. In one of the Caribbean islands, he started working as an HPB surgeon in 2022. Guys, we are in the 21st century, and the surgeons have just started becoming a specialist, the very first specialist in their country. So there's a huge, specialist workforce, then perioperative mortality rate, something that you were saying. It's good to know the technique, but what's the outcome of the patients that are being operated with whatever resources that you have? So we need the data. And then also the patient has to be in the center of it all, because what is the catastrophic expenditure they may end up into if they have this HPB surgery that they have? Yeah, can they afford? Are they going to go below the poverty line if they have to pay for this surgery? So how can we imagine HPB surgery within the health system of that country? Yeah, because they have a pool set of funds to give universal access to surgical care for HPB surgery, for example. And we prioritize on the quality as well as we prioritize on the access. And then we prioritize on the range of services that HPB surgery can offer. So these are some of the more complex health system-based approaches that as a global surgery HPB community we need to consider when we are talking about working in low-resource settings. And it starts with understanding the health systems of that very country. And I think we all need to be advocates for global surgery in HPB, because this point really needs to be made obvious that there aren't any HPB surgeons in a lot of sub-Saharan African countries, and God knows in some other South American countries and Southeast Asia. So this is a real problem and really needs to be highlighted in IHPBA. Thank you.
Good morning. I'm Allie Martin from the U.S. And good to see Dr. Betty. So proud of you. That was amazing. Amazing. So everybody has done such a beautiful job this morning. I was actually so happy to hear your talk in particular, because hearing the comments go around earlier after the case presentations, the word that was like flashing in my mind was, you know, this humility issue. Because as I hear people presenting, there's this sort of vein of self-consciousness, like, am I doing the right thing? Will these surgeons from the US and Canada and Europe think I'm doing the right thing? And truthfully, you of course you're doing the right thing for your context, because you're clearly all putting the patient at the center of the equation, which means, yes, of course you were doing the right thing. And so I thought your talk in particular was incredibly important, doing this qualitative analysis. So perhaps there will be interest in looking over time, you know, the psychological impacts of HPBridge on clinicians, on the patient population, on the multidisciplinary teams at the partner institutions, and what the having the availability of this resource does for feeling like having this confidence that you are doing what is right in your specific context. And then the other comment I had was with regard to this. It was another humility sort of comment. Was we should suspend our self-confidence that what we are doing, where we've written all these papers and even done great randomized trials, we should think about the social context in which these trials have been performed. And so when we see somebody doing a total pancreatectomy, giving capecitabine afterwards, we shouldn't say, oh, that's clearly the wrong thing, because that's not what MD Anderson would do, and I trained at MD Anderson. We should think, we don't know anything about the social context within which these care pathways, treatment recommendations are being delivered. It's entirely different. Like I practice, my primary practice involves a lot of people from rural America, and I have to shift what I do. It doesn't mean I can't call my mentors from fellowship and get their perspectives, but I don't know what the impact of the environment of rural America is on my patients' biology, on their surgical outcomes. So we really shouldn't have so much confidence that we know that all the papers that we've written in the studies that we've enrolled patients in, that's the best thing to do. We actually don't know what the impact of social context is, and so hopefully HPBridge in the future can give us more data in that particular arena where we're looking at biology and how your geographic location, environmental associations are impacting our patients' outcomes. So this is super exciting, and I'm just very privileged to be here among all of you, so thanks so much.
Hi, morning. Thank you once again. If I look at the benefit of the initiatives such as this, I just want to maybe put one question or plea or suggestion forward to the IHPBA in terms of our setting. I mean, it's great to be able to make decisions together. It's great to be able to tailor things to our own setting. But I think one of the themes that I've seen very recurrently in the recent past is how we don't have data from Africa or from sub-Saharan Africa. So in as much as we are discussing cases, we are having academic discussions about how we should do things, is there a way that we can use these initiatives to sort of gather our own data regarding what we're doing? And are they, you know, our research culture within Africa is very primitive, if I can use that word. We're still at the infancy of our research. We don't have valid or we don't have active databases. We don't have active registries. Is there a way that through this initiative we can actually be helped with that? So starting at least at the bottom where we can start collecting data, and then that can help us to come up with publications, or at least with our own numbers for the future. Is that something that can be done through this?
Thank you. Fantastic thoughts and comments.
Thank you for a fantastic session. And I come from Sweden, the country of registries. So I see many opportunities of sharing knowledge and structure and how it can be built. And that's, I would say, a big part of our research comes from registries. So that would be great if we could provide that.
Please, final comment.
Okay, thank you very much. So the opportunity as well as the importance of HPBridge is already mentioned. I will not going to talk on that. Just 3 comments if it's possible. So, pardon me if I have repeated it from the previous speakers. One is about the learning and education. So I'm happy that you have raised about the issue of seed money is just for or funding is for researchers, and you have also raised about the skill transfer, particularly on the hard skill, that means the surgical skills. That's very important, but still what we forgot is about the soft skills. So particularly the research capacity that we have in sub-Saharan Africa is very low. So I also recommend you to design a mechanism by which you can also boost the research capacities in the sub-Saharan Africa. So you don't need to come physically, still videos and the others or virtual trainings and the like can work. And the other one is the collaborations to the South-South. So that means there are even we are not also in a position to talk each other like in sub-Saharan Africa. So design mechanisms and to link the South-South collaboration and support that to facilitate. And the last one is linkage with industries. So what I mean linkage with industries is, so there are companies who are interested in having information from sub-Saharan Africans and still we're going to come up with the resources who can support. So IHPBA do have also that opportunity. So I think that is also the other thing which this group also think about and proceed forward. Thank you very much.
Isaac, last word to you, please.
Yeah, I can see IHPBA bringing change to the practice of HPB in low middle income country. But one thing is unique about change is that it's difficult and it takes time. So as many of us that are involved in HPBridge, sometimes if we are not careful, I thought we've discussed about this last session, they should be doing this. You need to take time because this context, the system is very different. The challenges that the people working locally are facing is quite unique. Probably you may not even understand the full context, which some of the things they battle with, lights, water, equipment, and all that, human challenges and the like. But one thing is sure, that IHPBA through this HPBridge has the potential to bring the needed change. And the only thing we need to put in our mind is that change takes time. And as we give that time to the change, we will see it in the next few years. Thank you. It's an excellent session. Happy to have all of you. And we'll continue the discussion around the corridor. Thank you.
So boy, forget about the world, 'cause it's gonna be me and you tonight. I'm gonna make you pay for it, and I'm gonna make you swallow your pride. Oh, and you done make me feel like I'm the only girl in the world, like I'm the only one that you'll ever love, like I'm the only one who knows your heart. And you done want you to take me like a thief in the night. Hold me like a pillow, make me feel right. Baby, I'll tell you all the secrets that I'm keeping. You can come inside. And when you enter, you ain't leaving me my prisoner for the night. Oh.